Hello everyone. In today's lecture, we'll be covering intravenous anesthesia, agents, and techniques. Today, we are learning about the drugs that make patients forget us instantly. Learning objectives. At the end of the lecture, we would be able to understand common intravenous anesthetics, propofol, etomidate, ketamine, barbiturates, their mechanism of action and pharmacokinetics, induction of anesthesia with IV agents, benefits and limitations of intravenous anesthesia, total intravenous anesthesia approach, sedation versus general anesthesia. We'll know the common anesthetics, understand their mechanisms, uses, pros, and cons, recognize clinical scenarios where each is best or dangerous. So, what's the fastest way to put someone to sleep? A lullaby, a boring lecture, or IV anesthetics? Obviously, IV anesthetics. Okay. Intravenous anesthetics. Intravenous anesthetics are fast acting drugs that are administered directly into the bloodstream to rapidly induce a temporary loss of consciousness and sensation for surgical procedures or sedation. Common examples include propofol, etomidate, ketamine, and barbiturates. These agents work by quickly reaching the central nervous system, allowing for precise control of anesthetic depth, and are used for procedures ranging from short interventions to the induction and maintenance of general anesthesia. Like the inhaled agents, no currently available intravenous anesthetic is an ideal anesthetic drug in the sense of producing all the five desired effects: unconsciousness, amnesia, analgesia, inhibition of autonomic reflexes, and skeletal muscle relaxation. Analgesia is no pain but big gain, and amnesia they don't remember like your selective memory for exams. Okay. Now, the clinical and pharmacological goals for an ideal anesthetic: property and category and the key characteristics. Efficacy: it causes rapid hypnosis and amnesia. Other beneficial effects, example, analgesic and antiemetic. Pharmacokinetics: it should be ultra rapid onset, one arm brain circulation time, rapid metabolism to inactive metabolites, accurate model based dosing guidance. And its safety profile: it should be minimal cardiorespiratory depression, no histamine release or hypersensitivity. It shouldn't be toxic, mutagenic, or carcinogenic effects. Its neurological profile: it should have no untoward effects like seizures, myoclonus, and neurotoxicity. And its property category and key characteristics, again, like solution properties: water soluble, stable and non pyrogenic formulation, antimicrobial preparation, and its administration should be painless on injection, non irritating, small volume needed for induction, ability to continuously monitor delivery, and its economic factors: inexpensive to prepare and formulate. Common intravenous anesthetics are propofol, etomidate, ketamine, and barbiturates. These drugs are typically given as rapid bolus through a vein, leading to quick onset of action. Each drug has its own unique pharmacological profile, which helps guide clinical use. So, next time you are giving IV anesthetics, remember they are like friends. Some calm you, some knock you out instantly, and some take you on a crazy trip. Okay, let's move on to the next slide. Propofol. It shows general information about propofol: chemical class alkyl phenol, not a barbiturate or a steroid. Formulation: white, milky emulsion, 1% lipid containing soybean oil, glycerol, and purified egg phosphatide. Propofol is also called milk of amnesia because of its white color. The most widely used IV anesthetic agent for induction and maintenance of general anesthesia. Its mechanism of action. Its primary mechanism is potentiation of the inhibitory neurotransmitter GABA, binds to GABA A receptors, slowing the closing rate of the chloride channels, increase chloride influx into the neuron, leading to the hyperpolarization and reduced neuronal excitability. Secondary effects may also block sodium channels and modulate calcium channels. Now, this Okay, this slide shows the basic concept, but let's break it down. So, how does this connect to what we just saw? So, what do you think will happen if this receptor is blocked? This is important because it helps us understand that propofol binds to GABA A receptor on the postsynaptic membrane. Think of receptor as lock and drug as key. GABA receptors are ligand gated chloride channels. Think of them as gates that opens and closes. Chloride influx occurs into the neuron because chloride loves to gossip inside the cell. It makes inside of the neuron more negative called hyperpolarization. Then neuron is less likely to fire an action potential. Action potential is inhibited, means signals don't get passed between neurons. So next time you think of receptor, remember no receptor, no reaction. On the right side of the diagram, we can see the clinical effects, which are sedation, anterograde amnesia, CNS depression, anxiolysis, anti-anxiety, and muscle relaxation. Okay, now if we look at the next slide, propofol, besides its use for induction and maintenance of general anesthesia, propofol is also used for profound sedation in the ICU as well as for conscious sedation and short duration general anesthesia in locations outside the operating room like interventional radiology setting or emergency department. To recap, that we learned about propofol that it's one of the most commonly used IV anesthetics. It acts rapidly and is ideal for induction. In most elective surgeries, like laparoscopic cholecystectomy, we use propofol to induce anesthesia. It allows for smooth induction and rapid recovery. But in patients with cardiovascular instability, we avoid it because it causes vasodilation and hypotension. Think of it like this mnemonic: P for propofol and P for pressure drop. Okay, now this next slide shows pharmacokinetics and clinical uses of propofol. Pharmacokinetic is how the body handles it. Its onset is extremely rapid, approximately 15 to 45 seconds. Time to one arm brain circulation. Distribution rapidly distributed to the brain, high lipid solubility, then redistributed to peripheral tissues. Its duration is short, 5 to 10 minutes after a single bolus due to rapid redistribution. Its metabolism is extensive hepatic conjugation to inactive metabolites, and elimination is via renal. Context sensitive half time is low, making it ideal for continuous infusion. And its clinical uses: induction of general anesthesia, primary use, maintenance of general anesthesia via continuous infusion, total intravenous anesthesia, sedation for mechanical ventilation in ICU, procedural sedation in endoscopy or cardioversion. Now its advantages and disadvantages. Advantages are rapid and smooth induction and recovery, clear headed recovery with less nausea and vomiting, anti emetic properties, no analgesic properties, but also no excitatory phenomena. Can be used for total intravenous anesthesia, low context sensitive half time, doesn't produce cardiac arrhythmia or myocardial ischemia, doesn't impair hepatic or renal function. Disadvantages and side effects: cardiovascular, dose dependent hypotension and bradycardia. Respiratory apnea is common and dose dependent. Pain on injection can be mitigated with lidocaine or larger vein. Risk of infection: lipid emulsion supports bacterial growth. Strict aseptic technique is mandatory. Propofol infusion syndrome, PRIS, rare but fatal metabolic acidosis, rhabdomyolysis, and cardiac failure with prolonged high dose infusions. Involuntary movements: propofol can produce twitching and seizure like activity. No analgesic properties. Propofol doesn't have analgesic properties. Okay. General information about etomidate. Now that we have covered propofol, let's move on to the etomidate. Okay, general chemical class is imidazole derivative. Formulation is a clear colorless solution available in propylene glycol or lipid emulsion formulation to reduce pain on injection. Key characteristics: it's known for its exceptional hemodynamic stability. Mechanism of action: primary mechanism is potentiation of inhibitory neurotransmitter GABA. Action: enhances GABA binding to GABA sub A receptor, increasing the duration of chloride channel opening. Result: increased chloride influx and neuronal hyperpolarization and inhibition of the reticular activating system, causing hypnosis. Hypnosis is loss of awareness or consciousness, lacks analgesic properties. Its pharmacokinetics and clinical uses. Onset: it's very rapid, approximately 15 to 45 seconds. Duration is brief, 3 to 12 minutes after a single bolus due to rapid redistribution. Metabolism: rapid hydrolysis in the liver and plasma to inactive metabolites. Elimination: renal 78% and biliary 22% excretion of metabolites. Clinical uses: induction of general anesthesia in patients with significant cardiovascular disease, example coronary artery disease, cardiomyopathy, hypovolemia, shock or sepsis, cardiac tamponade, or rapid sequence intubation RSI in the emergency department. Let's switch to the next slide. It shows the advantages and the disadvantages of the etomidate. Excellent hemodynamic stability, minimal effects on heart rate, contractility, and systemic vascular resistance, rapid onset and recovery, low incidence of allergic reactions. Disadvantages and side effects. Adrenocortical suppression inhibits 11 beta hydroxylase, suppressing cortisol and aldosterone synthesis, a concern in critically ill patients or with prolonged infusion. Nausea and vomiting, higher incidence than propofol. Pain on injection, very common, especially with the propylene glycol formulation. Myoclonus: involuntary muscle movements occur frequently, 30 to 60% of patients. Now, etomidates, it's the gentleman. It's considered in hemodynamically unstable patients. Let's say you have a patient with severe headache, severe heart failure who needs emergency intubation. Most anesthetics can depress the heart, but etomidate has minimal cardiovascular effects, making it safer choice. Etomidate is equal to stable heart. Let me simplify this. In simpler terms, E for etomidate, E for emergency, and E for endocrine suppression because it suppresses adrenal steroids. Coming up on this next slide, ketamine. Okay, general information about ketamine. Its class is aryl cyclohexylamine, phencyclidine derivative. Formulation: clear, colorless solution available as a racemic mixture of S plus enantiomers. Key characteristic: a dissociative anesthetic that provides profound analgesia and amnesia while preserving respiratory drive and airway reflexes. Its mechanism of action: it's a non competitive antagonist of the NMDA and methyl D aspartate receptor. Action: blocks glutamate, the primary excitatory neurotransmitter at the NMDA receptor. Result: creates a functional dissociation between the thalamus and the limbic system, leading to a cataleptic state. Now, what is cataleptic state? Patient has open eyes, slow nystagmus movements, appears awake but is disconnected from the environment. Also has opioid receptor and anticholinergic effects. Let's switch to the next slide. Ketamine pharmacokinetics and its clinical uses. Onset in when giving IV 30 to 60 seconds and intramuscularly 3 to 5 minutes. Duration: intravenous 10 to 20 minutes and intramuscular 20 to 40 minutes approx. Metabolism: extensive hepatic metabolism. Norketamine is an active metabolite. Elimination: renal excretion of metabolites. Clinical uses: induction of anesthesia in hypovolemic, asthmatic, or shocked patients. Procedural sedation and analgesia. Example: wound repair, fracture reduction. Adjuvant for analgesia is a low dose infusion. Treatment of refractory depression, off label sub anesthetic doses. Okay. Now, this slide highlights the key points about the advantages and disadvantages of ketamine. Advantages: stimulates cardiovascular system, increase heart rate, blood pressure, cardiac output via catecholamine release. It has sympathomimetic properties, potent analgesic at sub-anesthetic doses, bronchodilation. So it's excellent for for asthmatics and preserves spontaneous respiration and airway reflexes. Its disadvantages and side effects: emergence reactions, vivid dreams, hallucinations, delirium during recovery, less common in children, and with benzodiazepine premedication. Increased salivation requires anti-sialolog, example glycopyrrolate, increased intracranial pressure and intraocular pressure, emergence, delirium, and nausea. I have mentioned several side effects. Do any of these surprise you? Okay. Now, see, ketamine basically, what I mean is ketamine is unique because it provides analgesia and maintains airway reflexes. Let's think about a situation. Imagine a patient is in emergency department after RTA, road traffic accident. His blood pressure is low. We avoid propofol. Instead, we choose ketamine, which maintains blood pressure. Or imagine a child with broken arm with no oxygen supply. You want a drug that produces sedation, pain relief, maintains airway reflexes. Here, ketamine is the ideal choice. Why is it useful? Because it doesn't depress respiration. It's safest in low BP. Crazy dreams, emergence, delirium is also caused by ketamine, while the patient is out partying in dreamland. A patient with asthma is also given ketamine because it's bronchodilator. Ketamine is the party drug because it causes dissociation and dreams. Imagine you give ketamine and your patient wakes up describing a fight with a purple dragon. So don't panic, that's ketamine dissociative anesthesia. Okay, now barbiturates. As you can see here, the general information about barbiturates, thiopental, or oxobarbiturated methotrexate. Formulation: yellow powder reconstituted in water to form a highly alkaline solution. Historical note: the original IV induction agent, now largely replaced by propofol but still used in specific settings. Mechanism of action: potentiation of the inhibitory neurotransmitter GABA, binds to GABA A receptors, increasing the duration of chloride channel openings, neuronal hyperpolarization and CNS depression is the result, decreased cerebral metabolic rate, and intracranial pressure. Okay, coming up on this next slide, it shows pharmacokinetics and clinical uses. Pharmacokinetics: extremely rapid onset, approximately 10 to 30 seconds due to high lipid solubility. Duration is short, 5 to 10 minutes due to rapid redistribution from brain to muscle and fat. Metabolism: hepatic oxidation and desulfuration to inactive metabolites. Elimination is renal excretion. Context sensitive half time increases dramatically with prolonged infusion. Clinical uses are induction of general anesthesia, now less common, rapid sequence intubation, treatment of elevated ICP intracranial pressure, conversion management, status epilepticus methotrexate. Its advantages and disadvantages: rapid, reliable onset of action. Advantage: neuroprotective, markedly reduces cerebral metabolic rate, and it's inexpensive. And disadvantages or side effects: cardiovascular depression, significant dose dependent hypotension due to myocardial depression and vasodilation. Respiratory depression, potent suppression of respiratory drive, cumulative effect with repeated doses, saturation of fat stores leads to prolonged sedation. Pain on injection and tissue necrosis if extravasated. And it's contraindicated in acute intermittent porphyria. B for barbiturates and bad, those are bad for porphyria. Okay, thiopental, it's used in settings, and these barbiturates are used in settings like status epilepticus. However, its long context sensitive half life and hangover makes it less ideal for day case surgeries. Thiopental is the old veteran who puts you to sleep quickly but hangs around like a lazy guest or magnet. Okay. Contraindications of barbiturates is a poor analgesic. In fact, barbiturates decrease pain threshold and increase pain sensation, hyperalgesia, inadequate muscle relaxation. A stage of surgical anesthesia is achieved very rapidly. Therefore, constant supervision is necessary to prevent overdosage. Okay, now we look at this slide. There are three types of receptors, each with its own personality. Okay, number one, yellow receptor. This one, GABA A receptor. Its type is inhibitory receptor and it opens chloride channels causing hyperpolarization. And drugs affecting it are propofol, benzodiazepine, sodium thiopental, and etomidate. And the middle one, the orange one, is a nicotinic acetylcholine receptor, which is excitatory receptor at the neuromuscular junction. And there is the ion movement is open sodium channels causing depolarization, and drugs that interact are thiopental and ketamine. And the third one on the right, the purple one, is NMDA, N-methyl D-aspartate receptor. It is excitatory glutamate receptor and it allows sodium and calcium influx and potassium efflux. So which drug do you think acts here? Ketamine blocks it. Okay. Okay, now if you look close at the table, that it's showing effects in nutshell. Effects of propofol on the heart rate, it has a minimal effect on contractility, it's reduced, systemic vascular resistance is decreased, mean arterial pressure MAP is reduced, respiratory depression, cerebral blood flow decreased. Thiopental heart rate increased, contractility reduced, systemic vascular resistance is reduced, mean arterial pressure is reduced, respiratory depression, cerebral blood flow is decreased via thiopental. And ketamine increased heart rate, increased contractility, systemic vascular resistance increased with ketamine because it is sympathomimetic. Mean arterial pressure increases, respiratory bronchodilation, so that's why it's good when giving in asthmatics, and cerebral blood flow is also increased. Etomidate has no effect on any of these, but it decreases cerebral blood flow and it causes functional inhibition of adrenal cortex. It reduces steroid synthesis. Okay, now we'll come towards this induction of general anesthesia with intravenous agents. What is IV induction? The rapid administration of an ultra short acting hypnotic drug via the intravenous route to transition a patient from a conscious state to a state of unconsciousness, anesthesia. The gold standard goal is achieve a smooth, rapid, and safe loss of consciousness, facilitate the secure replacement of an airway device, endotracheal tube, or laryngeal mask. The arm brain circulation time. The critical concept is the time it takes for the drug to travel from the IV site to the brain, typically 20 to 45 seconds. This dictates the speed of onset. Okay, advancing to the next point, the process and common agents, the step by step process. First one is preparation, second is administration, and third one is the loss of consciousness. Preparation, pre-operative assessment and checklist completion. Example, WHO surgical safety checklist. Apply standard monitors, ECG, saturation of oxygen, and NIBP. Now, what do you mean by NIBP? It is the NIBP. What is NIBP? It shows that what is it like bronchopulmonary pressure. Pre-oxygenation, 3 to 5 minutes of 100% oxygen to denitrogenate the lungs and create an oxygen reservoir. And give administration. Give the calculated doses of the IV induction agent as a rapid bolus. And common agents are propofol, etomidate, and ketamine. Propofol is the most common agent, smooth induction, rapid recovery, and side effect is hypotension. So, which IV drug do you not want to give in trauma with blood loss? So, the answer will be propofol because it loves to crash the BP faster than the Wi Fi. But it's the most smooth, quick, but watch out for the heart. Okay. And loss of consciousness occurs within approximately 30 seconds. Signs include loss of verbal responsiveness, eyelash reflex, and drooping of the head. Okay, now shall we dive to the next? Key advantages and considerations. Title: Why choose IV induction? Key advantages: fastest method to induce unconsciousness, avoids the unpleasant smell and feeling of suffocation associated with gas induction, smoothness, bypasses the excitatory stage 2 of anesthesia, reducing risk of coughing or laryngospasm, enables rapid sequence induction for patients at risk of aspiration. Essential considerations and risks. Airway management. Practitioners must be proficient in managing the airway and ventilation. Ventilating the patient as apnea cessation of breathing is a common and expected effect. Cardiovascular stability. Drugs like propofol can cause significant hypotension. No going back. Unlike inhaled agents, the dose can't be washed out once administered. Absolute requirement depends on secure and functional IV access. Okay. Benefits of IV anesthesia induction: rapid and controlled onset. Speed of induction achieves unconsciousness within an arm brain circulation time, typically 20 to 45 seconds, significantly faster than inhalation induction. Smooth transition avoids the excitatory phase, stage 2, with gaseous induction, reducing risk of coughing, laryngospasm, and delirium. And dose control, titratable to patient's response. The anesthetist can administer a precise dose based on the weight, age, and the clinical condition. Okay, let's switch to the next slide. Cardiovascular stability. With certain agents, propofol provides a smooth decrease in blood pressure, which can be beneficial in hypertensive patients. Antiemetic properties. Propofol has intrinsic antiemetic effects, reducing post-operative nausea, vomiting, PONV. Clear headed recovery promotes a rapid and clear emergence from anesthesia, often with less confusion and delirium compared to some volatile agents. Coming up on this slide, we just covered this. Now let's see how it connects to the points on this slide. Improve patient acceptance, avoids the unpleasant smell and feeling of suffocation associated with inhalation mask induction, preferred by most adults and older children. Operating room efficiency allows for rapid sequence induction, crucial for patients at risk of aspiration. Facilitates quick securing of the airway, endotracheal intubation soon after administration. High predictability, well defined dose, guidelines, and consistent pharmacokinetics in healthy patients leads to the reliable outcomes. Okay, moving forward, lack of titratability post injection. The drug is locked in after a single bolus dose. Unlike inhalation agents, its level can't be easily lowered by reducing delivered concentration. Context sensitive half time. The duration of action prolongs significantly with longer infusions or repeated doses. This makes predicting wake up times difficult for lengthy procedures. No built-in analgesia. Most IV agents, propofol, provide hypnosis but no pain relief. Analgesia, analgesics, opioids must be co-administered. Okay. Transitioning to the next concept, cardiorespiratory depression. Common and potent causes dose dependent hypotension and apnea, requires vigilant monitoring and readiness to support blood pressure and ventilate the patient. Pain on injection. A frequent and notable drawback, especially with propofol, can be mitigated with techniques like lidocaine, pre-treatment, or using larger veins. Allergic reactions. Although rare, anaphylaxis to IV agents like propofol, egg, soya, lecithin, or neuromuscular blocking drugs given concurrently can occur, like succinylcholine. Now, the limitations of IV anesthesia induction. Dependence on IV access. Absolute requirement. It's impossible in patients with no viable intravenous access, pediatric, obese, or trauma patients. Inability to confirm drug delivery. Unlike inhalation agents, which have end tidal concentration monitors, there is no real time way to measure blood levels of IV drugs. Limited ability for single agent anesthesia. IV induction is almost always just the first step in a balanced technique requiring other drugs, opioids, muscle relaxants, and inhalation maintenance. Okay, total intravenous anesthesia. What is total intravenous anesthesia? A technique for maintaining general anesthesia using continuous intravenous infusions of hypnotic, example propofol, and analgesic remifentanil drugs without the use of inhalation anesthetic agents which are volatile gases like isoflurane, and the core principle balanced anesthesia via IV. Hypnosis, analgesia, and muscle relaxation. Hypnosis is typically provided by a continuous infusion of propofol. Analgesia, provided by continuous infusion of a potent, short acting opioid like remifentanil and alfentanil. Muscle relaxation is provided by bolus doses of neuromuscular blocking agents as needed. Key rationale for using total intravenous anesthesia. Avoidance of volatile agents, beneficial for procedures where volatiles are problematic, like prolonged neurosurgery, malignant hyperthermia risk, because these volatile anesthetics cause malignant hyperthermia. Superior post-operative nausea and vomiting profile. Propofol is antiemetic, avoiding volatiles, reduce PONV risk. Environmental considerations eliminate the release of potent greenhouse gases, volatile anesthetics into the atmosphere like nitrous oxide. Okay, advancing to the next one. Delivering total intravenous anesthesia safely and effectively. The essential technology target controlled infusion concept. A computer controlled pump uses pharmacokinetic models, example Marsh Schneider for propofol, to calculate the infusion rate needed to achieve and maintain a user set plasma or effect site concentration. Benefit automates dosing for a more stable anesthetic depth compared to manual infusion regimens. Critical requirements for safe total intravenous practice. A dedicated IV access, a secure patent IV line is mandatory. Any interruption leads to rapid lightening of anesthesia. Depth of anesthesia monitoring. Tools like bispectral index or entropy are highly recommended to titrate hypnosis and avoid awareness. Now, this BSI, bispectral index, is used to monitor depth of anesthesia in patients undergoing surgery. Delivering total intravenous anesthesia safely and effectively. Another concept like understanding of pharmacokinetics, clinician must understand the context sensitive half times of the drugs used. Safety checks always have a drawn up induction dose of propofol and emergency drugs available. Double check that vaporizers are turned off. Advantages versus disadvantages. Advantages are reduced post operative nausea, vomiting, PONV, no operating room pollution, like with the volatile anesthetics, which are gases mostly, ideal for MH, malignant hyperthermia susceptible patients, better for neurophysiological monitoring. Disadvantages risk of accidental awareness, more complex, expensive setup, requires vigilant monitoring and no washout option. Now, what do you think happens when we give total intravenous anesthesia? If I give an example, total intravenous anesthesia versus inhalation in daily life, gas anesthetics like volatile inhalation anesthetic, like cooking on a stove. Total intravenous anesthesia is like using an electric oven, clean, precise, and no smoke. Now, sedation versus general anesthesia. Sedation is not sleep, it's Netflix mode. You are still online but less responsive, or in other words, sedation is like dimming the lights, not switching them off, or like YouTube buffering. Can sedated patients respond if you shake them? Yes, but if they don't, congratulations, you have gone into general anesthesia. Now, what's general anesthesia? It is the off switch of consciousness. It's like putting the brain on airplane mode. Now, let's see. What this slide is about: monitored anesthesia care, MAC, a drug induced depression of consciousness during which patients respond purposely to verbal commands or light tactile stimulation when you touch them. Cardiovascular and respiratory function are maintained. Now there's three types: minimal sedation, anxiolysis; moderate sedation or analgesia; conscious sedation; deep sedation or analgesia. Minimal sedation, the state is normal, responsive to verbal commands. Cognitive and physical function is unaffected. Example like when you administer the dose of benzodiazepine for anxiety. Moderate sedation or analgesia is like purposeful response to verbal or tactile stimulation. No intervention needed to maintain a patent airway. Cardiorespiratory function usually maintained. Example, propofol Infian for a colonoscopy. And deep sedation, not easily aroused, but responds purposefully after repeated or painful stimulation. Airway may require intervention used to maintain a patent airway. Spontaneous ventilation may be inadequate. Cardiovascular function usually maintained. Example, deep sedation for a complex orthopedic procedure. Okay, now this next slide, coming up on this. General anesthesia, a drug induced loss of consciousness during which patients are not arousable even by painful stimulation. The ability to maintain ventilatory function independently is often impaired, and cardiovascular function may be affected. State unconscious and unresponsiveness. Airway requires assistance to maintain a patent airway, example, endotracheal tube or laryngeal mask airway. Positive pressure ventilation is often required, cardiovascular function often significantly affected. Okay, now let's move on to the next slide. There's a key differences this table is showing: sedation versus general anesthesia. In sedation, consciousness is depressed but maintained. In general anesthesia, there is complete loss of consciousness. And responsiveness is purposeful to stimulation in sedation, but there is no any responsiveness in general anesthesia by the patient. Airway, patient maintains, may need support in deep sedation, but in general anesthesia, anesthetic secures and manages the airway. Ventilation is spontaneous and may need oxygen in sedation, but it's controlled or supported in general anesthesia. Cardiovascular, usually stable in sedation, but in general anesthesia, it's often significantly depressed. Recall, memory, variable may have amnesia in sedation, but in general anesthesia, there is none, no any recall, and that is the goal of the anesthetist. Clinical applications. Sedation is ideal for minimally invasive or diagnostic procedures, endoscopy, cataract surgery, cardioversion procedures under local regional anesthesia. Patients where avoiding airway instrumentation is preferred. General anesthesia is required for major surgery like laparotomy, open heart, intracranial, procedures requiring a profound muscle relaxation, cases where patient movement would be catastrophic, patients who can't tolerate the procedure, awake or sedated. Okay, now in the last, I had just all right to wrap up. I have listed a few questions. These are designed to help you reflect on what we discussed today. Let's take a look at the scenario number one. Pay attention, the slide is high yield. A 65-year-old man with severe ischemic cardiomyopathy, ejection fraction is 20%, requires rapid sequence induction for emergency laparotomy. He is normotensive but has dry mucous membrane head and poor skin turgor. Which intravenous induction agent is most appropriate for this patient? Etomidate. Explanation: this patient is in compensated shock, severe cardiomyopathy, positive signs of hypovolemia like skin turgor. The patient and the priority is hemodynamic stability. Etomidate provides the most stable induction profile with minimal effects on heart rate, contractility, systemic vascular resistance. Ketamine could cause catecholamine mediated tachycardia and increased myocardial oxygen demand in a heart with no reserve. Propofol and thiopental cause significant dose-dependent myocardial depression and vasodilation, likely leading to cardiovascular collapse. Okay, now if you are half asleep, this slide will wake you up. Clinical scenario number two, a healthy 25-year-old patient is scheduled for elective knee arthroscopy under general anesthesia. GA induction is performed with propofol. 60 seconds after loss of consciousness, the patient develops a heart rate of 45 beats per minute and a blood pressure of 80 by 40 mmHg of mercury. Which property of the administered drug is most likely responsible for this effect? Our answer will be B. Dose-dependent myocardial depression and vasodilation. Profound dose-dependent hypotension and bradycardia are characteristic side effects of propofol due to direct myocardial depression and decreased systemic vascular resistance. It's not primarily mediated by anticholinergic effects, histamine release, or sympathetic blockage. Okay, now see, we have talked about it. Now let's see how it relates to that in this slide. A neuroanesthesiologist is planning an anesthetic for a craniotomy for tumor resection with intraoperative motor and speech mapping. Which anesthetic technique is most ideal for this procedure? Now let's see. Total intravenous anesthesia with propofol and remifentanil. Total intravenous anesthesia with propofol and remifentanil is the gold standard for many neurosurgical cases requiring neurophysiological monitoring. Example, motor evoked potentials, somatosensory evoked potentials. Inhaled anesthetics, especially at high doses, can significantly suppress the amplitude of these signals, interfering with accurate mapping. Total intravenous anesthesia provides a stable anesthetic depth without this interference. Now, the fourth one is a patient in the ICU has been receiving a high dose propofol infusion for 72 hours to facilitate mechanical ventilation for severe ARDS, acute respiratory distress syndrome. The nurse reports a new onset oliguria, a metabolic acidosis, and hyperkalemia. Creatine kinase levels are found to be markedly elevated. The presentation is most consistent with which diagnosis? C. Propofol infusion syndrome. To connect the dots, this explanation demonstrates PRIS is a rare but fatal complication of prolonged high dose propofol infusion for greater than 48 hours with a dose greater than 4 to 5 mg per kg per hour. The classic triad includes metabolic acidosis, rhabdomyolysis, elevated creatine kinase, hyperkalemia showing muscle damage, and cardiac failure or arrhythmias. Oliguria is a consequence of rhabdomyolysis and renal injury. This presentation is pathognomic for PRIS propofol infusion syndrome. Okay. On this slide, the focus is on during a deep sedation case for an endoscopic retrograde cholangiopancreatography ERCP. The patient stops responding to verbal commands and doesn't grimace or cough with endoscope movement. Capnography shows a wave form with a respiratory rate of 4 breaths per minute. The next most appropriate action is to now the option will be C. Provide gentle jaw thrust and positive pressure ventilation via mask. The patient has progressed from deep sedation into general anesthesia, unresponsiveness, no response to painful stimulus, the endoscope. The slow respiratory rate and apnea indicate inadequate spontaneous ventilation. The immediate action is to support the airway. Jaw thrust and ventilation, bag mask ventilation to prevent hypoxia and hypercarbia. This is a primary rescue maneuver for unintended deep sedation. Okay. A patient with history of acute intermittent porphyria requires an emergency appendectomy. Which induction agent is absolutely contraindicated? I've told you earlier, porphyria contraindicated barbiturates, thiopentol. Notice how the slide emphasizes on the contraindications of barbiturates. Barbiturates are potent inducers for the hepatic cytochrome P450 enzyme system. This can trigger acute porphyric crisis by inducing the rate-limiting enzyme aminolevulinic acid synthase in the heme synthesis pathway, leading to a buildup of neurotoxic porphyrin precursors. They are absolutely contraindicated in porphyria. Okay, now thank you for listening. And remember, anesthetics don't just put patients to sleep, but they also wake them up. And I look forward to seeing you apply this knowledge in practice. Thank you.